Okay, well, let's get started. Welcome everyone to Open Office Hours with the AAOA. This is a program we started this year in response to our members' needs. We were asked to provide a forum where members could show up, ask questions, and get help with hot topics affecting their practices, either by the pandemic or just in general. And over the course of the year, we've done several of these, and they've been very interesting. And we've been recording them as well, as not everyone is able to show up on a Sunday evening. So thank you all for being here, those who are going to help me answer the questions, and also those who are showing up as participants. We've also learned over the past year that office hours, even though they are open and anyone can ask any type of question they want from the leaders of the AAOA, we also have suggested some topics, which are topics that have been brought to us by members with questions and complications and issues that have been coming up recently. And so for tonight's open office hours, we have two topics that we'd like to suggest. The first being office-based procedures, and the second being dosing of immunotherapy. I'd like to thank all of my panelists for being here as well to help me: Dr. Katie Marzouk from Syracuse, Dr. Sandra Lynn from Baltimore, Dr. Emanuel from San Francisco, Dr. Gavin Setzen from Albany, Dr. Hunter Hoover from Charlotte, North Carolina, and Dr. Jim Conley from Louisiana. And so welcome to all, including those AAOA members who join us this evening. Over the course of the pandemic, we learned that we needed to do things differently, that our business models were upended. And one of the things I think affected all of us was the ability to have access to the operating rooms. Office-based rhinology has been around for a long time, but I do think that the pandemic definitely changed and sped up the implementation of office-based rhinology. And so I'm interested, I know some people do more than others, and I think that there's definitely a trend, a difference between academic groups and private practice groups in terms of the types of patients in rhinology that they're seeing and operating on, and maybe also the availability of operating rooms. And so I'm just gonna first just start with my experience of office-based rhinology, and then I'd like to ask some of our panelists to also comment on their experience and how they approach office-based rhinology procedures. I'm in an academic practice here in Boston, and I have much less experience with office-based procedures. I have full access to ORs and a surgery center, and so I feel like I could do the best work I can with patients asleep. And so my office-based experience is limited to turbinate reductions and nasal polypectomy. Now, I know that I've spoken to friends in the area who are in private practice and have a little bit different patient population, and they tell me that the majority of their practice is rhinology practice is procedures in the office, including full endoscopic sinus surgery, balloon sinuplasties, valve surgeries, turbinate surgeries, and I consider the full works of anything you could do that I could do in the OR. And so that's my experience. And so I'd like to hear from some other people about their experience with office-based rhinology, and then we'll just get into some questions. Do we have a volunteer to go first? Maybe Dr. Setzen from Albany.
Sure.
What's your experience?
Thank you, Mike, and glad to participate. Appreciate the opportunity. So we're a private practice group, 9 docs and 9 PAs. And so we, over the last, I would say, probably 12 or 13 years, we've been doing a significant amount of in-office work. In our current environment, we have an ASC upstairs of the office. We do a variety of procedures, many of which you mentioned. I think the complex sinus disease, extensive polyp disease, more involved revision sinus works, neoplasms and so on, we certainly do in the ambulatory surgery center under general anesthesia. Most of the stuff in the office is anxiolysis. It's a level 1 center, so we don't need any specific accreditation per se. and patients are fully able to protect the airway, no concern about cardiovascular or airway issues, but we also monitor those patients, continuous pulse ox, BP, and heart rate, for example. And so we've modified, we have 2 suites in the office where we can do these procedures. We have Scopus for in-office imaging and the full range of equipment and technology, as is the case in the OR. And it really, I think, depends on patient selection, the extent of the pathology and the comfort level of the surgeon as to, what cases are done in the office. Certainly, endoscopic sinus surgery, limited revisions, mucus recirculation, synechia, turbinate work, the more, limited nasal valve procedures, Latera, and cryoablation and balloon, procedures for the eustachian tube or sinus disease. And what we found surprising is how much over the years patients are willing to tolerate and how comfortable and effortless it seems in the office with appropriate preoperative planning, counseling, informed consent, topical and local anesthesia. And it's remarkable what patients will tolerate and their preference to do that. They pull into the parking lot, they hop into the office. Within 15 minutes, they're having their procedure, they go home. Thank goodness, for the most part, these are uncomplicated procedures, and to that, patient selection obviously is very important, and managing expectations. So I think for all of those reasons, maybe heightened in the pandemic era, where patients were less keen to go to an operating room or a hospital-based facility, that tendency increased as well. So we've had a very favorable experience, and patient preference, as well as the cost savings involved in being able to do something out of a hospital-based system or HOPD, even an ASC, in the office. So without getting into more detail, can certainly hear from others and be glad to answer other questions related to that from the private practice experience.
Wonderful. Thanks, Gavin.
Of course.
Does someone else want to give us their experience? Haiti, you're in Syracuse.
Yeah.
Tell us about your practice and what your experiences with office-based procedures.
Sure. I'm also in an academic group at the moment. However, part of our practice setting is actually remote, from the hospital building, and kind of about 10 miles away from our main hospital. And I think that when you're talking about kind of the extent of work and the extent of kind of pre-medicating your office-based procedures, I think it's important to kind of take those things into consideration, right? What resources and monitoring, like Dr. Setzen was referring to, you kind of have available, and kind of what patients you're dealing with. So in my office setting, we do pre-medicate patients and then use a combination of topical and local anesthetic. And we, in the different offices, we have availability for balloon procedures. I'll do some ethmoidectomy work, balloon work. I can do traditional maxillary enterostomies in the office, turbinate reductions. We also have availability of Clarifix and Latera, like Dr. Setzen was mentioning. I think, though, he hit the nail on the head with, I think, patient selection and disease process selection in terms of what you're able to accomplish in the office successfully. And one thing that I would add is some of the revision work I actually find quite favorable to do in the office, because a lot of our patients that we do traditional sinus surgery on, we're following over longer periods of time, and sometimes they need a tweak And a lot of times that nasty septum you already, that would have been in your way in the office, you already took care of with a first surgery. So people that have mild syncytiae, some narrowing here and there and need little tweaks, the office is a great option for those types of procedures as well. And it kind of helps keep you optimized. The other thing is in-office drug delivery systems, like steroid-diluting implants and things of that nature for your, the patient that you really went to town with in the OR for their extensive polyposis. The office-based procedures for kind of those nice tweaks for steroid-diluting implants and things of that nature can be really nice to add to your armamentarium to keep your patients optimized after their first surgery.
Great, thank you. Both of you did mention anesthesia and pre-medication. I'm interested to hear more. Is that typically oxycodone and a benzodiazepine? Is that as far as you'll go for pre-medication, or is there something differently that you would do?
Typically, I'll use a benzodiazepine. Certain patients without Phenergan, possibly. Some patients also pre-medicating them with a narcotic. They are counseled about the medications and the effects. They are driven to and from. They are wheelchair escorted from the procedure room to the car and back and so on. So all of those precautions are taken, but that is extraordinarily helpful. And then, topical followed by local, and most of the standard regimens are more than adequate. Just leaving enough time for the topicals to work, and certainly enough time for, I use 1% lidocaine with epi, and preparing, patients in adjacent rooms makes that much easier. And I think those patients who have good prior expectations have a decent amount of pre-medication and are well treated with topical and lidocaine, really experience little if any discomfort, and some of them are quite surprised at the end of the procedure that one is done, and have never had to abort a procedure due to anxiety or inadequate pain control.
Have you ever had to augment more benzos or more pain medicine in the middle of the procedure, or do you just do a pre-op one dose and that's it?
So we'll pre-medicate the patient an hour before leaving to come to the office. And if there's still a high level of anxiety or concern, we'll always make it such that the dosing, depending on the age and other meds and various cytochrome P450 and so on, may remedicate them in the office. So they bring their meds with them. And if necessary, we'll just proceed with the next procedure, come back to that person. But when starting the procedure, they're usually very comfortable.
Great. Does anyone do any higher levels of anesthesia? Or that's pretty much it?
Again, when you're in an office setting, if you're in a hospital-based practice and you have some availability of resources with monitoring or things like that, but I think, when you're dealing with accreditation issues, like Dr. Setzen was mentioning, to go even higher, you do need some extra layer of, I guess at that point you're dealing with conscious sedation, which has an extra layer of red tape to go through. The other thing that I would just add is that when we talk about, especially the dosages of benzodiazepine given to patients pre-op, I've heard a pretty wide range of dosages in terms of, dosage and potency of benzodiazepine that different people get or give for their office-based procedure. And I think that that's something probably that comes with time, as you do more of these. And also there are certain blocks that you can utilize when you're doing the office-based procedures that also can make the patients quite comfortable.
Yeah, I would agree with that. I'm always concerned in over-medicating, especially an older patient, and tend to rather low dose if possible. And I think walking and talking the patient through the procedure every step of the way. How are you doing? Raise your hand if you have a concern or if there's pain. I'm going to be doing X, Y, or Z. You'll feel some pressure. You may hear a little snap, crackle, pop. You can really walk patients through this very comfortably. And that oftentimes eliminates the need for additional analgesia intraoperatively.
Great. Dr. Lin, you're also at an academic medical center, and I'm interested, it seems like there are differences in practice patterns between an academic center and private practice. What is your experience with office-based procedures?
We don't do as extensive of office-based procedures. We're very limited in our ability to do monitoring. And actually, I have to say that with COVID, our staffing situation has been really tight. We're having difficulty staffing our clinics. So I will do like in office, we have can do the radio frequency ablation and turbinate and for vasomotor rhinitis and some balloon, but we don't really have extra staff that are even able to stay with us in the room or provide monitoring. And that was even pre-pandemic, and it's become even more difficult. So in our setting, it's probably not very realistic. We also have a lot of trainees with us. And so I think some of the patients have some apprehension, with the trainees doing procedures. It depends the level of the trainee, of course. We have some quite skilled senior, but when you have a very junior resident with you, it does limit what they can do. So I don't think we have, unfortunately, some of the resources available to us for in office. And so we still do primarily OR based, but we, do have some, like the steroid eluting stents and balloon and, cryoablation, those types of things we certainly do, or radio frequency of the nasal valve. So we do those types of things in the office.
Great. Dr. Hoover, you want to tell us about your practice?
Some in private practice, but to be honest, my practice is a little bit skewed. We have about 35 ENT doctors in my group, and some of them do a fair amount of office procedures. Majority of my practice is actually more endoscopic skull base and complex revision polyp surgery. So I'm sort of like you. I don't do as much in the office just based upon the patients that I tend to see. So mine end up being turbinate reductions and polypectomies, but I personally don't do balloons or other extensive type procedures in the office, mainly because of the patient population I see.
Good. So I'd like to open it up. If anyone has any questions, they're welcome to chime in here. They can always raise their hand or put it in the chat as well. But anyone else who's on it have a question about something one of the panelists has said about their practice, or if you open up to any questions.
Well, I have a question. So there was a comment, the comment was made about the variation in dosing of pre-medication. So what do y'all use specifically?
I can start and say that I've never pre-medicated someone. That all my procedures are just done under local. I inject and I put topical. So Haiti, do you want to tell us how you pre-medicate?
Yeah, so I usually use Lortab, I guess a hydrocodone Tylenol mix, and depending on kind of the caliber of the patient, I will either do 1 tab or 2 tabs about 1 hour before the procedure. And actually, in terms of benzodiazepine, I do only 10 milligrams of Valium. I've heard people go all the way up to 30. I guess I'm more conservative in terms of my benzodiazepine dosing, but I do write for more than one. So as Dr. Setzen alluded to, if somebody is on, I feel like the 10 isn't doing it, we might tack on another 10 before the procedure when they're in the office. How about you, Dr. Setzen? What do you use?
Similarly, so I tend to be a little conservative in that regard. Diazepam 5 to 10, maximum of 20. A lot of it's based on the history and other medications, and you can kind of get a sense of what patients may or may not tolerate. And also, you know, hydrocodone, oxycodone, and literally half a dozen for the post-op, just so that somebody has something on hand in the event that they need it. Post-operative pain control is usually never an issue, and you know, have them use extra strength Tylenol alternating with ibuprofen. Sometimes we'll use Phenergan, depending on the patient and the history, and you know, any potential nausea, vomiting. A Dansitron for somebody with a history for post-operative management, but usually not a major factor. But I tend to be conservative in the dosing, and we have very strict preoperative counseling regarding the meds, post-operative, the opioids, expectations, driving, working, etc., so that it's clear, written, consented to, etc.
Hey, Mike, can I ask one more question?
Yes, we can.
A technical one. Suction. How many suctions do y'all have when you're doing these procedures? Because generally you have one suction in the room, but if you got something hooked up to a microdebrider, but then you also want a suction separate from that, do you end up with two suctions in your room?
Yeah, so we in the procedure rooms have an SMR unit, and the procedure room is larger than a regular exam room and is fitted out with image guidance and all the other tools and so on. But throughout our office, we have dental suction. So it's centralized, and basically we don't use SMRs, which need to be, you know, emptied and cleaned, and except in the exam rooms. So we have two suction units. Yeah, the procedure room, rather, two suction units.
Yeah. And Katie?
No, I do not have that luxury. We switch back and forth.
I only have one suction also. I want to go back to the prior question though. Does anyone else have a different dosing scheme for pre-medication for procedures? Okay, good. And Paul, you had a question as well?
Yeah, thanks. A few people mentioned monitoring during the procedure. I was wondering, like, what specifically you do to monitor, and do you have an additional staff member there to, you know, keep an eye on pulse ox or something, for example? I have not done that in the past, especially if I'm talking to the patient. I have not felt the need to monitor them, but curious what you all do.
Yeah,
So
I haven't
I use
monitored either because I didn't pre-medicate. But for those who do, I think that would be great to know how you monitor.
Yeah, and these patients are fully awake, able to communicate, completely responsive during the procedure. We use a Welsh Allen device that has, you know, a BP cuff that stays on, pulse oximetry. And so we're measuring heart rate, BP, and pulse ox. And it's lined up facing me, as is the Scopus monitor. And so literally, with alarms, you know, I'm looking at all those monitors, and you know, you can tell when the heart rate picks up, or pressure changes, or you know, any indicator that there's anxiety, pain, or something more ominous. And while it's not necessary, I just feel that it's an added safety precaution, and God forbid, in the event of a bad outcome, you have taken the necessary steps. The other thing I was going to comment on, that as otolaryngologic allergists, we're all fully prepared to resuscitate patients. And so the staff, you know, all our staff are BLS and ACLS trained. And so again, God forbid there's a problem where, you know, you can intubate and treat an anaphylaxis or whatever, just like the rest of the allergy practice. So I think there's a little bit more of a comfort level being able to manage that aspect.
And do you record the monitoring similar to an anesthesiologist, or is it just a one-time documentation of normal vitals throughout the procedure?
So we monitor, we document at the start, at one point during, which is random, and post, and then before the patient actually leaves the room to leave the office. but it's not a continuous monitoring like in the operating room with a printout.
So you have 4 sets of vital signs, so you clearly have someone helping you.
Yes, yes. So there's an MA/tech, with me the whole time for the procedure. And we'll just capture those data points at different times to enter them in the EMR.
Excellent. Does anyone have any other questions?
I have also a logistical one. What are the greatest challenges you guys have faced in terms of getting reimbursed or coding some of your in-office procedures?
That's a great question. I think that I also have the question related to that, which was, you're putting in a very expensive stent. Is that covered, or are you taking a risk when you do it? So the billing around office-based procedures, that's a big question. Does anyone want to help with that?
Sure. And that's the crux of the matter. And I think being certain that you're able to do the procedure, every single procedure in the office, whatever it is, prior auth, pre-cert, and we've had our revenue cycle management team meet with the major payers in our market prior to introducing a procedure. Every procedure is well discussed, explained, the CPT codes and ICD-9s and so on, the data, so that we know that we will get covered. Obviously, a lot of challenges with some of the newer technologies, and some are still considered investigational and experimental despite 2-year and other data. But the drug-eluting stents and so on, it took us a long time, but you have to know your payers in your market and work with them to ensure that those procedures are covered in prior auths, pre-certs, whatever it takes. And having patient expectations clearly met beforehand regarding co-pays, deductibles, co-insurance, etc., so that that whole RCM component is addressed before the patient arrives.
With all the no surprise billing kind of rules that we're facing now, do you have the patients sign documentation in advance of office procedures regarding lack of reimbursement or anything like that?
Yes, but each patient specific to that procedure, we know before the patient comes, and the patient knows what is covered, what is considered out of pocket. The one issue with no surprise, if we're sending tissue off to the lab, that they know that they will incur a separate independent charge potentially for the pathology. That's the only part that's not covered. But certainly, when we meet with the insurers and they look at the data as it relates to reimbursement, medical clearance, blood work, EKGs, chest x-ray, anesthesia, etc., it's an order of magnitude lower in the office, and they are quite willing to work with us to facilitate that process. And so we're still developing our No Surprise Act in the office. So it's very complicated, and that's evolving. So it's on the radar, and it's on the radar for patients.
We'll make sure to get more tips from you next time then.
Well, I think that one of the earliest office-based procedures that we did in rhinology was turbinate reduction. And I still think it's one that probably applies to most of our patients. And the one thing that we could really do well in the office and save patients trips to the operating room. So I just want to talk a little bit about the turbinates. And for me, a good turbinate reduction requires that I'm able to see well the entire turbinate. I do it generally with an endoscope, regardless of whether I'm in the office or in the operating room. And I know there's lots of different technologies to do it. If I could say that when I'm in the operating room, I feel that I could do the best job most likely with a microdebrider. But yet in the office, I'm limited. I don't think I could do a really great job with a microdebrider and an endoscope in someone's nose. And I often use radio frequency in the office the same way under endoscopy, being able to see the entire turbinate from posterior to anterior, make sure I'm staying submucosal. Can anyone else share their experience with me about office-based turbinate work? Any tips or challenges?
Well, I can say something. It's the one procedure I do in my practice, which is radiofrequency turbinoplasty or turbinate, reduction. And it's probably the best procedure I've ever done in my career, which spans about 40 years, because it gives the most relief with no pain and no bleeding. And that's what we love. I just pre-medicate with 5 milligrams, usually of Valium, depending on the weight of the patient. I use topical. I spend a lot of time anesthesiing with, just local, and then some with some Q-tips, and then I use lidocaine, usually without epi, although I sometimes use epi. And so I think the most important thing about the procedure is the anesthesia, and then I just use my eyes because I never trained with an endoscope. And I find I can do just as well. The whole procedure itself takes less than 10 minutes, and I get incredible, great results. Everybody's happy. So that's, I'm a single practitioner, and it's probably, as I said, the easiest procedure and the best results you ever get on someone who can breathe afterwards with no pain and no bleeding.
Great, thanks, Ivor. Does anyone else want to share their experience, any of their tips?
Yeah, I would echo what both of you have said. It's an incredibly satisfying procedure, particularly for somebody who doesn't want to have septal work done to improve their airway. And for many years, I mean, coming out of residency, I believe we were doing radio frequency in the late 90s. I do believe that the results are better with submucosal resection, and for the last 7-8 years I've been doing those in the office, and also am a big proponent of out fractures, and oxymetazoline left in place for 10 minutes followed by 1% lidocaine. I do use epi carefully, and the patients do fine with a SMR and an out fracture, and no packing or anything, a little cautery at the entry site, and that's it. And as Ivor said, it takes, minutes.
So Gavin, I
How
have
far
not
back
done
with the
out
shaver
frac-
do you go?
Go
Sorry.
ahead, Haiti.
I was asking,
Using
how
an
far back on the turb do you go with the microdebrider?
The length of the turbinate under
Oh.
endoscopic guidance.
Okay.
Yeah.
So I haven't done out fracture under local. Do other people have experience doing out fracture in the office?
Yeah.
And it goes okay?
It
If you
does. You
can't-
just have to prepare the patient. Yeah, a lot of pressure, and
the sound.
Yeah, the little crackle, and that's a good thing. It's a good sound.
So I also use a microdebrider under endoscopic guidance to do the full length. My question is, for those doing radio frequency, now we're back to the coding question. How do you end up coding an RF reduction of turbinate?
Well, I think I'll start out not being a coding expert by saying that there are multiple RF wands. There are some that are just a needle point, and then there's others that suction, irrigate, and actually remove tissue. And so it's not just RF, it's which device you're using, whether you're removing tissue or just heating tissue. Because I think there's two separate codes, and if you're gonna do the submucosal one with, the one's removing tissue and one is just burning. But someone who knows codes better can correct me.
That's it.
My understanding, and I hesitate saying this, it's more of a question, I guess. My understanding was that to truly billed for a submucous resection and required removal of both soft tissue and bone.
Fine.
I wasn't aware of that, and I don't think a microdebrider, that turbinate blade that I use that's very small, actually removes any bone. If I wanted to remove bone, I think I'd have to take something like a through biting forceps and chomp away at the bone. But that's a minor technicality. I think that if you're removing submucosal tissue, I don't think that much bone gets removed with either device.
Agree.
Mike?
I would say if you're suctioning out any tissue, whether it be radiofrequency or microdebrider, my instinct would be to go with the 30140, which is the submucosal resection. And if I do something like a submucosal, like a needle probe, a cautery, or radiofrequency with a needle, I tend to lean towards a 30802, which is just kind of a submucosal ablation of tissue without removal.
I do the same thing. I think there was another question out there from iPad, who I'm not sure who that is.
Hey, Mike, Alpin here. Just wanted
Hi,
to make
Alpin.
a comment about the CPT codes. Thanks for giving me a minute. So I just kind of piggyback on the last comment. So 30801 and 30802, I think, is what Hunter is referring to. Both are radio frequency codes. One's superficial ablation, right? So that's the 30801. I tend to use that with the Aaron medical device, the Vivera device, when I'm not actually penetrating the mucosa of the inferior turbinate. And then when I do penetrate the turbinate mucosa with radiofrequency energy, and I tend to use, Smith Nephew's product, which is the Coblation PTR turbinate handpiece, then I'll use, like the last comment, the 30802. And then, of course, 30140 when you're doing a submucosal resection like you are, either with that turbinate blade or a quad cut or tri-cut microdebrider, which of course can eat up some of the bone, or you can use those turbinate scissors and then re-drape the mucosa. So I don't know if that helps, but that's what I tend to do with turbinates.
Alpin, do you use the scissors for the quad cut in awake patients in the office?
No, all in the OR.
Great. Well, do we have any other questions about office-based procedures? I think we'll talk before moving on to our second topic. I think one more interesting topic is discussion of the nasal valves. And there's several new interesting procedures to address the nasal valves. I personally don't have much experience myself. I have seen other patients who've had either an implant, a nasal valve implant placed in the office, or a radiofrequency procedure to specifically address the nasal valves. Does anyone want to make any comment about their experience addressing nasal valves in the office? Has anyone tried putting in implants?
I use the Latera implant and have since we were in the clinical trials, and find it very easy to do and good results and high level of patient satisfaction, and similarly tolerance for the procedure is very good.
I have limited experience, and I usually see the patients who don't have as favorable outcomes. And so I have seen some patients who had it who have not had improvement, and also an extrusion of an implant, which wasn't that big of a deal. But I've been trained on the device, and it looks pretty easy to do under local in the office. How about radiofrequency? Does anyone have experience with radiofrequency? Oh, Sandra, did you?
I have done some. I've noticed, and this is just anecdotal or in my mind, but I've noticed that my younger patients seem to do better with that. I don't know if it's their tissue, how their tissue reacts, as opposed to the people who see in my practice who have done the worst are older, thin skin. The younger patients really have done well. So I don't know if anybody here has noticed that similar experience who's doing it.
Are you talking about in terms of the efficacy or in terms of side effect complications?
Yeah, for the effectiveness,
Right.
like in the patients I've done, who have done well, it's typically younger patients.
Right.
And patients where the results have not been, as robust, older
Right.
patients, thin skin. So
It may be also that the older patients have more severe valve collapse because of so much more laxity
Yeah.
of their cartilage and enlargement of their cartilage. Those are the ones I think have worse valve collapse. It may just be severity.
it may be. So, but I didn't know if anybody else had noticed that in their experience.
And I think to your point, Sandra, again, patient selection is so important, and expectations.
I think though, one of the things that the patients do like, and we do discuss that this may not take care of your issue, and is that they have other options in the operating room, and so the ones who are choosing are the ones perhaps who are reluctant to go to the operating room for a full procedure, but they're willing to do some things smaller in office.
Right, and to that point also, advising patients that if this alone does not take care of the problem, there are procedures under general anesthesia or revisions or more extensive options available.
Excellent. You don't burn any bridges by doing them. I think that's a great point.
I mean, when we counsel the patients, I usually give them, these are several options, and available to you. So, that they know that there's a full gamut, and some of them may choose not to do an in-office procedure and goes, straight to a more comprehensive nasal valve surgery. And that's fine too.
To piggyback on that comment, I have a question. I don't have a lot of nasal valve surgery experience, but doing the Ryanair, the Vivair procedure, how much more difficult does that make a subsequent nasal valve repair in the operating room, if at all? I wonder that sometimes if I am burning a bridge. I've only done a handful, to be clear, but.
Well, I usually send them off to our facial plastic surgeon, so I'm not the right person to ask.
Yeah, it's a good point because you're doing radiofrequency from the inside and maybe scarring or burning the inside. But I feel like my facial plastic colleagues, when they do it, they're doing an open rhinoplasty, so they're coming from above. And so even if they're scarring from underneath, I don't think it limits it. And like Sandra said, it's not us who has to deal with it, but I haven't heard any problems from facial plastic surgeons. They can open any nose they want.
And they will.
Great. We have just one more comment here. Thank you for that comment from Craig Paulson, who just mentions that he does Latera as helpful for patients who have lateral wall collapse and who may have had a septoplasty in the past and may need a bigger surgery, but it does save them another big surgery, open rhinoplasty. And so that's a great point. Patients undergo septoplasty and then they're not happy afterwards. And all of a sudden you find out well, what's really the valve? We've all seen those second opinions. That's sort of like a nice, smaller, easy procedure that you can make an unhappy patient a happy patient without doing a big intervention. That's a great point. Thank you. Excellent. So do we have any other questions or comments about office-based procedures? And we're going to talk about immunotherapy dosing next. Great. Well, Sandra, thanks so much for being here because I do consider you to be the sublingual immunotherapy world expert. And dosing is a question that we often get for not just sublingual, but also for subcutaneous. Last time we were on with the office hours, Jack and Alan brought us a very great question about taking over a general allergist practice and how to convert dosing from one to the next. We in the AOA, we teach at our courses dosing that I think is somewhat standard for subcutaneous, for sublingual. And we do talk about different options for if patients aren't doing well or if patients can't tolerate certain doses and backing off. But as a group, I feel like we are very cohesive in terms of our dosing. When I look and talk to my colleagues in the general allergy world, it's a lot more diverse. There's lots of more different dosing schemes in terms of vial preparation, how often they're giving shots, and what is the maximum doses that they're get up to. And so there's a lot more variability. So I think we should first talk about sublingual because we're fortunate to have Sandra here. And Sandra, could you give us just some of your thoughts about optimal dosing for sublingual immunotherapy? Because I know there's just so many dosing schemes out there.
I mean, and Hunter's on here too, and I know we've talked as far as there are, though, I would say probably as more people have been doing sublingual immunotherapy for more extended periods of time, I think there are more approaches, and I don't think there's one that's wrong or right, because we know that there's certain allergens that may need higher dosing, and then, you know, what's tolerated by the patient as well. And also then there's the issue, I mean, to throw in there too, is a very high cost of allergen for sublingual immunotherapy, because you have to use so much compared to injection immunotherapy. So I think many people use has, something that they were comfortable with at the beginning, and then some people are pushing doses higher. Some people are limiting the number of allergens they treat. So I think that comes with experience, and also managing patient expectations, and, what are the prevalent allergens in your area. So.
Yeah, those are all great points. I generally limit to allergens that are symptomatic, that clinically make sense. And I try to increase the doses for those, as opposed, and I guess the other issue of cross-reactivity, not trying to put too much cross-reactive stuff in there. So you get higher doses of ones that are clinically meaningful. But I do see others who are treating for as many things as they can at lower doses. And I think it's a little bit of an unknown. We've seen studies that show low dose also has benefit.
I mean, there are still some unknowns, and that's the truth.
Yep. Now the FDA approved tablets are all what I consider very high dose. And so that's basically why I use as my justification for using higher doses, that the FDA approved ones are high dose. But you're absolutely right in terms of costs. It becomes unaffordable if you put too much. Go ahead, Gavin.
Yeah. No, I was going to say antigen costs are so high on sublingual compared to subcutaneous. And it's interesting, Jack, so you're taking over Quad AI practice?
I did, yeah. I've already taken it over.
And because, it's interesting, we see a lot of patient referrals because of different testing techniques and thresholds and so on. I'm curious, your perception, how many of those are negative patients that we see, we retest them over time and, they come back quite allergic. Your confidence level taking those over and converting them?
Well,
concerns.
Well, the practice I've got is a 35-year-old practice, 40-year-old.
Wow.
And a very good friend of mine was forced to retire. And I basically, what we've done is I have all of his records, and each patient, it depends on the patient. I've got a lot of patients that have been on immunotherapy once a month for 20 years and more. And I say, how about getting off? And you may as well tell them to, give you $1 million. They're not going to do it.
Right.
And so we're continuing everything that my friend did. They all have their vials. They made up vials before he quit. And as the new ones come up, we're changing from Greer to Hollister Steer. And we figured out a way to do it. His dosing is very different than ours. He uses much higher quantities of antigen, but our Hollister Steer antigens are hotter than the Greer. So that's something we've been finding.
When you say hotter, you mean more concentrated?
Not more concentrated, just more robust. It has to do with the way Greer makes their antigens. They make them a little differently than Hollister. So that's been nice. And then what I told Michael, what we're doing is we're giving out RQLQ questionnaires, the mini ones, to all of the patients. And what I'm going to do is I'm going to do it for a block of time now. Now's a big allergen season for us. So we're going to give it out for the next couple months to everybody. And then in a year from now, we're going to do the exact same thing. And what I want to see is, I want to see, you know, if we can tease out some differences or maybe not.
So you have two
And I
groups, one with a higher
apologize if I
dosing.
missed this in the beginning. Are you treating them with subcutaneous or sublingual immunotherapy?
Oh, all sub-Q. We don't use sublingual.
So you have two groups. You have one group that's higher dosing from a general allergist that you're continuing, and then your group. And that's gonna be really interesting to see differences
Yeah.
over
But
time.
actually the higher dose ones, they're running, as their vials run out, we're then switching them over to our dosing.
So
So,
it might be some confounding factors in the data. But at least for the
well,
first,
not really, because we're going to switch them over. We're keeping track of all that. And then we're going to see if there's a difference between the higher dose and the lower dose over the next 1 to 2 years.
yeah, that is a very challenging study because so many patients are so different. You know, every patient's different. And then these
They are.
patients have been on it for a long time. They may have already gotten their benefit and they may expect it to get continued benefit. It's gonna be fascinating.
Yeah, but we're getting some good history. Yeah, I know what you mean, but we're gathering good data, and no one's done it before that I've ever known of. So, is it perfect? No, but it's the best shot we have, I think. I mean, because as we've talked about offline before, is we dose it the way we do, and prove I need proof that what the general allergists do is better, or what we do is better, or it's the same. So, short of doing labs and checking for blocking IgGs and doing some of that stuff, this is about the best I have.
Well, I would say in some ways it's better because primary outcomes on all these studies are usually symptoms and medications, and secondary outcomes are the immunologic markers. So I think it's great that you're doing it.
We shall see.
Just a comment, Jack, to your point where you can't get patients off immunotherapy for all the money in the world. That speaks volumes about what we do as otolaryngic allergists, and the beauty and the power of being able to offer that as, different than another script or a surgical procedure. And it's funny, Ivor and Jamie will know, I took over the practice of Arnie Rappaport, and he was a past president of the AAOA and started practicing in the 70s. There are still patients I see 40 years later that you cannot get them off immunotherapy, no matter how hard you convince them. It's great.
Well, I'm old enough to have patients that started in the 70s with me, which is too bad, but I mean, but I do things totally different, as most of you know. I only use dosing 1 to 10. I don't do the 5-fold. Quantitative, I find with sublingual is not as important. You don't need to, you just need a yes or no test, because the dosing, at least the way I do it, doesn't depend on the score that you get. So whether it's a number 3 or a 5, it doesn't matter. If they're positive, where I am, we have a massive dust mite community, and I have to prove that someone's not dust mite allergic when they come in with chronic nasal symptoms in my practice, which I either do with skin testing and or in vitro testing, because if both are negative, then they're not IgE positive. And there's about a 15% crossover. There's about 15% of people I find that show up on the skin test, that don't show up on skin test, and the same with in vitro. But when I get a positive for one of those, I mean a decent skin test positive, then you know that you're going to treat them for dust mite, and they've got all the symptoms, and that's what's prevalent, at least for dust mites. And then I use the strongest dose I can get, which is a 1 to 10 dilution of dust mite. And for what I charge them, I still have a reasonable margin, profit margin. And I've had over 500 patients over 30 years. I've been doing this, some of you know, since the early days, but some of you were still residents. And And I found, you know, it's variable. I mean, you do get people that are fantastic within 6 months, and then others that take a year or two, and then others who never want to go off, and others who don't feel it's going to work. But, you know, you can't tailor, you don't need to tailor it. You just use the strongest dose you can use that you can afford, which I do now. I literally use a 1 to 10 dilution. And I've done this over the years. I started with, before people were even doing sublingual, I was worried about anaphylaxis and was I overdosing and malpractice. But as now sublinguals become accepted, I've pushed the doses to the maximum that you can afford, which is basically a 1 to 10, because otherwise it becomes outrageously expensive. And that seems to have worked for the majority of people. As far as the pollens go, I do similar, but I don't treat more than 5 pollens, which are the most prevalent in my area. They're the cause of most of the symptoms, grass and then some trees. It's very common in Northern California. We have olive and oak and cedar, and that's about it. You know, a couple of elms and grass pollen, and they have different seasons, so you can sort of tell when they are. We have very easy symptoms, easy diagnosis with history, and I push the dose as high as I can, although sometimes you'll have to dilute them. If you don't start them during the season, you can go a little stronger. And again, you're going to get variable results. But you don't have to do 5-fold. It's all about qualitative, not quantitative. They're positive, because you're going to still try to use the strongest dose you can. And Jack, just to let you know, I just use Paul Fass and I have been using 1 to 10s. We haven't used 1 to 5s in 30 years. And
For your testing?
In testing too. Absolutely. And it's very simple, because you're really with sublingual. I don't do subcutaneous anymore. My patients in San Francisco, you know, most of them are techies. They're all young. They don't want to come in and get shots every week. I mean, I'm on the 12th floor of a building where you'd have to park and spend a lot of money. I get them started in my office and I mail them their drops every 2 months, and they love it, you know, and they're all doing, most of them, you know, those that are going to do well are going to do well. Some won't do well. This doesn't matter what dose you use. And it's simple.
Ivor, what is your approach with molds, and do you use mixers?
You know, I do use, there are very few people that I find are mold positive, whether on vitro or with prick testing. Those that are, I'll treat. Mostly the most common molds are Alternarium, Cladosporium, and there may be a couple of others, but those are the 2 big ones that I'll put in. And I also treat a lot of pet allergies like cat and dog, and I go, again, the highest dose I can. And you know, they'll tell you that they're allergic, but you know, again, you just need a skin test or a IgE test. I don't do serial endpoint. I mean, I stopped that. You know, it costs a fortune. I mean, you know, it's time consuming. I do my skin test. I can do 10 a day myself. And if I don't find what I'm looking for from the history, I'll send them to the lab, and they're quite happy to do that. And I'll use the combination as my diagnostic tool, and then treat them with the dose that I know is the highest dose that I can possibly afford and give them, which, as I said, I've had great results. I have hundreds of patients on it, but that some are obviously maybe some placebo, but there are a lot of them that come in and within a year are not using medication.
Do you prepare, do you use
30 years of experience to tell you at least on this, so.
Do you use mixers?
No. Well, I mix the vial. If I'm doing pollens, I'll put, you know, the 4 pollens. If they show up, whatever shows up on their test, I'll put in the bottle. And, you know, but that's it. I don't go and put 50 allergens, because half of them don't exist in my area anyway. And they're not important in terms of symptomatology. I mean, I'm lucky, I guess, because in my area, it's very clear what trees are blooming when. You know, the top of the alphabet bloom in February and March, and the bottom of the alphabet bloom in March and April, and then May is grass pollen season. And they're very distinct. And so you can tell by your symptoms and your history what's really wrong. And if the patient gives me, you know, a negative test, then they're not allergic. But most of them will come up with a positive cedar or oak. And then I don't need to know what dilution I'm going to give them. I'm going to give them the strongest that I can give them as the extract. And I'll put those 5 or 4 pollens that work. Some will just have cedar. I mean, cedar is very common. Cypress, cedar, juniper are very common here. And there was some studies done, and I know myself, anecdotally, we have a big Asian population, and it's much more common in the Asian population, cedar, cypress, juniper allergy, than it is in the Caucasian or African-American population. So, you know, just by being in, practice for 35, I've been in practice now for 42 years. I've learned a lot. So, it's older than some of you guys that are alive. So, there's a lot that comes with that. And you don't, I've done all my own studies, that with the AAOA 10, 15 years ago, I present lots of studies, but, it's just seeing and taking note of what your patient's doing. So it can be made really simple and cost effective. That's what I'm trying to say with all the other stuff that goes on.
Well,
But you have to
excellent.
change your mindset a little bit.
Sure.
Ivor, thank you so much, and everyone else, for all of your great insights and your questions. And it was a very quick hour that we got through. So
Can I make one comment, Mike?
Yes,
before
please.
we close out, and only just to present a different side. When it comes to dosing study, we've had multiple placebo-controlled trials looking at dosing, and specifically when it comes to sublingual, we got tablets. And we know from the clinical trials with tablets that there's effective doses, less effective doses, and ineffective doses. And I just don't think that with drops, you're going to be able to do any better than you do with tablets. And I think we got to be very careful about making sure that what we deliver with drops is at least the dose that's being delivered with tablets that have been shown in placebo-controlled clinical trials to be effective dosing. And if you do that, you're going to find out that your dosing between the different allergens needs to vary, and that the dosing is going to need to be more than 1 milliliter in a 10 cc vial. It's just based upon clinical trials clearly demonstrate that the dosing needs to vary between the different allergens. And as such, you're going to have to, for me, I pick and choose which allergens to put in there. Because I still use a 10 cc vial, I just limit the number of allergens I put in there and make sure I use one that has an effective dose.
Sandra, do you have anything you want to comment about that?
I mean, I don't disagree, and that there are studies, that show the range of effective dosing, but I don't think I'm probably as aggressive as Hunter is in pushing up some of the doses. And I do have to say, I've been doing sublingual since 2008, and I have seen, unless it's an amazing placebo, because, at the beginning, I think I wasn't as aggressive at pushing up dosing because you're learning how to do something and you don't want to cause any harm. And, I think that's how a lot of people here in the United States started, right? And so I have patients who are off medicines, off immunotherapy, and they're doing great and improvement in quality of life. And the other thing I do have to say is that I do, for the sublingual, I do appreciate that I have allergens available to me with the drops that are not with the tablets. We have a very significant tree allergy, as I itch my nose, tree allergy issue, in the Maryland area. They don't have those available in tablets. And I'd say that's one our largest seasonal and most symptomatic allergens are trees. So I do appreciate the flexibility. I check in with my patients really frequently, even after they've been going, because what I will do is sometimes I will push up the dose as far as number of drops given. And I do meet with them and check in with them at least every 6 months for an appointment to see how they're doing. There is a lot of, and I have found there is, some individual variation. I like to see them during their most prevalent season, and I will push up the dosing for some patients, but not every patient seems to require that.
I would like to echo that as well. I think it's a complex issue. I think that there are, even before these placebo-controlled FDA-sponsored studies, there were also lots of other good studies that showed that there was efficacy at lower doses, and it really depends. I also started at lower doses, and now I agree I do higher doses because those studies, and the Leatherman paper was one that looked at all the different dosing regimens, and it showed there's a wide range. I also have patients that do exceptionally well and some that don't, and tracking them is really important. And so I do favor higher dosing, but I still think that there's room in there. There's some of the art of figuring out how do you get the most in there that's the most clinically relevant for that patient in the right season to make a difference for them? And it's a work in progress for everyone. Excellent. So thank you everyone for being here, for sharing these great comments. And hopefully you'll all be able to join us at the AAOA course coming up in Miami. Have a great night, everyone.
Thank you.
Thank you, Mike.
Thank you, everyone.
Take care. Good night.
Thank-
Good night, everyone.